Good day, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation of the series that we have started what surgeons should know, and it's about inflammatory bowel disease. And as a brief introduction, inflammatory bowel disease is one of the interests of the colorectal surgeon if we are talking about surgery. So don't expect to speak briefly about it, but we will keep in mind the title, what surgeons should know. I advise you to pay attention more to what I'm going to say than to what's written. I will try to summarize. I will try to highlight the most important topic that should be mentioned. Again, and always in my lectures, I used to say I never add my own opinion. It's just what's written and what's I summarize from my sources. Okay, inflammatory bowel disease is a general term that describes the chronically relapsing intestinal inflammation. We will see later that it's divided mainly to Crohn's disease and ulcerative colitis, and there are other entity. We will mention them later. The incidence worldwide is increasing, and especially in North America and North Europe. But we also mentioned that there are increased in the incidence of inflammatory bowel disease in area where the prevalence was low, such as Asia and Africa in a short period, and this may support the environmental explanation of the disease. Also, a well-known association is the Ashkenazi Jewish, I hope the pronunciation is correct, the Ashkenazi Jewish descent or ethnic group, regardless of their location. So this may support the genetic explanation. If we are talking about the causes or the etiology, if we want to just one single classic answer, so it's unclear. But if we want to be more professional and talk deeply about that, so we can say that it is multifactorial, multiple etiologies, multi-explanation. One of the simple way to classify them, they sometimes classify them as external or environmental cause and internal or host cause. Of the internal causes are the genetic causes, the immunity and the intestinal bacteria or microbiome. Of the external causes, there are the antibiotic, we will see the urbanization, industrialization and change in the lifestyle, the non-steroid anti-inflammatory drug, there is an association, and smoking and diet. These are explanation of inflammatory bowel disease. If we are talking about the genetic explanation, and to be honest, we are not going to talk about every single cause in details because it's extremely complex. This is one. Plus, it's not fully understood. It will not give you finally that this is 100% correlation. But it's wisdom to know that there is an evidence of a genetic correlation of inflammatory bowel disease and inflammatory bowel genetic correlation or genetic relation or genetic explanation for the inflammatory bowel disease according to the population-based study. There are about 10 there is about 10 great risk of inflammatory bowel disease among relatives of ulcerative and Crohn's disease. About 15 patients who are affected with Crohn's disease have a family member that are affected with Crohn's disease also. And I want to mention here that the Crohn's disease is more associated with genetic or more explained with genetic causes more than ulcerative colitis. Always the relation or the percentage of affected people who can be explained genetically are more with Crohn's disease than with ulcerative colitis. Always in genetic study, the monozygotic and dizygotic twin helps us. So, for example, in monozygotic twins who are one of them are affected with inflammatory bowel or with Crohn's disease, the other twin will be about 50% affected. So good concordance. And in contrast, the monozygotic twin who are affected with ulcerative colitis, only 15 are affected with ulcerative colitis. So 50, 15, this support the genetic explanations of Crohn over ulcerative colitis. Okay, we can add also that that child have about 25 increase in risk of Crohn disease, 25-fold risk increase in risk of developing Crohn disease if his another sibling have Crohn disease, and only 9-time increase in ulcerative colitis in a child who have sibling affected with ulcerative colitis. Actually, the gene that are explaining the inflammatory bowel disease is not one gene. It's polygenic. It's not simple or Mendelian gene. It's polygenic, and these genes are usually in multiple loci on the chromosome, so it's hard, and they are not usually not associated with only inflammatory bowel disease, but also with other autoimmune disease. So the causative relation is not clear. This is one. In some cases, it could be just one monogenic cause, one single gene that can be directly related to Crohn's disease, and they found that this monogenic or one gene, if we are talking about one gene, it's associated with the early development of Crohn's disease. Early development means less than 5 years, or very early development of Crohn's disease, less than 2 years. So we are talking about pediatric age group. Okay. What else we can add here? Okay. Here what we say that it could be associated with other autoimmune disease. Regarding the mechanism, how the gene can affect the or how can it appear as inflammatory bowel disease, so there are many explanations. One of these genes can lead to disruption of the epithelial barrier, and this will reduce the clearance of bacteria by the neutrophil, and so the intestinal microbiome and the intestinal bacteria will change. Other gene will cause autoinflammation and hyperinflammation, and interleukin 10 deficiency, which will cause ultimately change in the intestinal bacteria. Okay, one of the first genes that have been associated well with inflammatory bowel disease is the NOD2. NOD2 means nucleotide binding oligomerization domain containing protein 2. How this gene can affect? This is actually, it affects the dendritic cell. The dendritic cell are responsible for activation of the leukocyte and clearance of bacteria from the intestinal from the lumen of the intestine, so there will be change ultimately in the intestinal bacteria. Other genes also are found, but as we said, they are associated with other autoimmune disease, so it's not clear if they are a causative or not, such as here interleukin 23R and PTPN2, and also IRGM, ATG16L1. I don't want to make this lecture boring, but it's I'm just mentioning it. You shouldn't. I don't think that you should remember more than the note two. The note two is important one, and these are other genes just to show you that it's a polygenic cause. Okay, uh, let's move a little bit down. Here in one of the texts, it make it extremely simple. I don't think. Okay, they classify it as inflammatory bowel disease gene 1, which they say that it's associated with Crohn disease mostly and located in chromosome 16, and inflammatory bowel disease gene 2, which is associated with ulcerative colitis. Okay, that's what we can say about the genetic cause. Let's move to the immunity cause. And actually, the most hard part of this lecture is the beginning. So try to be a good soldier and fight to the end. Okay. And also regarding the immunity, it is alone, is not developed to the end to explain inflammatory bowel disease. Actually, what's written in this text is a general information about the immunity, how is the adaptive and the innate system are affected, how is the T and B lymphocyte is deficient, how some certain cytokine are affected, how is the intestinal lumen are full of the immune system, such as you can see the dendritic cell, the Paneth cell, the T lymphocyte. How can the dendritic cell penetrate and present itself to the T lymphocyte as receptors? Actually, no one single information I can deliver for you as a general surgeon, except to remember that immunity is one of the explanations. Again, they start to talk about the gene not 2 and how it affected. Okay. I don't know if this information can help. Interleukin 17 and interleukin 22 are found to be deficient. Also, some cytokines such as cytokine 1, 2, 3, 17, and 9 found to be affected. I don't want to disturb you, and I don't want to. I'm trying my best not to make this lecture cloudy or a little bit boring. About the intestinal microbiome, and the concept of microbiome is general. It includes bacteria, viruses, and fungi, and all of them are affected in inflammatory bowel disease. Also, a clear explanation to the end, a clear association does not exist, but we found that there is alternation in the intestinal microbiome of inflammatory bowel disease compared to the healthy patient, in a form that the diversity or the richness is less in inflammatory bowel disease patient compared to the healthy patient. The change in bacteria, if we are talking about the bacteria, it could be some bacteria can be increased and some bacteria can be decreased. And also, is this a cause or this a consequence of the disease? We don't know. We know as there is inflammation, the oxygen will be reduced, so there will be the aerobic bacteria will be less, the non-aerobic bacteria will be increased. Is this as a consequence? This is cause. Again, we don't know. Of this causative agent is there. For example, if you are talking about bacteria, enterobacteria, such as E. coli and the adherent invasive form, are found to be more in patients with ulcerative colitis. Mycobacterium avium, some texts call it the paratuberculosis, and they found that it may be a inducer of the granulomatous colitis, and sometimes they say that it is the infectious cause of our infectious agent of inflammatory bowel disease. E. coli, as we said, these agents are decreased. For example, the Rhinococcus, Acinetobacter, Bacteroid are decreased, and the Faecolobacterium brownsii are decreased. These are increased. Regarding the viruses, we said also there are change in viruses such as caudavirals, Xenococcus phages, Retroviridii family also are increased. Candida albicans are found to be more, and Saccharomyces cerevisiae. I hope the pronouncement is right, and I want to say again that in some studies they found that even in healthy patients this alternation can be found. So a full explanation of the disease according to the intestinal microbiome is still developing. We are waiting for more study, and the Nobel Prize is waiting for us. Antibiotic. And we know, as we take antibiotic, the intestinal microbiome will be changed. And this led to many studies that found a correlation between antibiotic and inflammatory bowel disease. Most of the patients, after they discontinue the antibiotic, the intestinal microbiome return to its normal. But in some patients, no. It's same. It will be continue and will not return to its normal bacteria. And this led to many studies. One of these studies, they found that pediatrics, children who are treated for otitis media with antibiotic, are found to be more affected with inflammatory bowel disease, especially the Crohn's disease. And another study found a correlation between all antibiotic except penicillin, and especially the ciprofloxacin and metronidazole are found to be related to inflammatory bowel disease. Yes. Okay, what we add? This is they are associated as I said, they are associated more with the Crohn and more with Crohn than ulcerative colitis. Here, the metronidazole and fluoroguanolone are most significantly associated with inflammatory bowel disease. Okay, actually, they, as we mentioned, they affect the intestinal microbiome. If we move to the environmental, or I name them the external causes, so urbanization is one of the explanations. And as we said in the beginning of our lecture, that some certain geographic areas such as North America and North Europe are the incidence of inflammatory bowel disease is more there. But now with the change of the industrialization mode, there is also increased in the incidence in the South America, in the Middle East, in Africa, in Asia. So this may highlight the environmental cause. Also, what we can add, what does urbanization mean? This is a general term including industrialization, change in diet, change in lifestyle, smoking, pollution. We cannot isolate the urbanization as a cause, but it may contribute or be a risk factor. They found intrinsically that rising in a rural environment can be protective. Also, what we can add about actually, they say that the prevalence is increasing worldwide because of the low mortality and the new diagnosis and early diagnosis and the modalities of the diagnosis that was invented. So this is what we can say about smoking. And the most interesting information in smoking, that smoking, active or passive, both active and passive, is a risk factor for Crohn's disease and protective for ulcerative colitis. The studies proven that. Why it's not clear. How can smoking affect or develop to inflammatory bowel disease? They said that it actually decreased the microvasculature. Here is it. Change in the microvascular and contribute to the inflammation and decrease the perfusion and recruitment of the immune cells. But why this occur in Crohn's and doesn't occur in ulcerative colitis? And one of the studies tried to found an association between the nicotine metabolism, which is found on the gene level, and they found that some nicotine metabolizing enzymes such as CYP2A6 were associated with the development of Crohn's disease on the genetic level. So this can explain how smoking can affect Crohn's disease. That's all. Okay, smoking is a risk factor for Crohn's, protective for ulcerative colitis. The mechanism decrease the perfusion and the recruitment of the immune cells. Why one is affected, the other is protective, we don't know till now. Non-steroid anti-inflammatory drugs. Also, studies have shown a correlation between the non-steroid and anti-inflammatory drugs, but in a high dose, more than 200 milligram per day and every day for more than 1 month is found to be contributor to inflammatory bowel disease. Lower dose, less than 200 milligram per day and not every day, doesn't correlate with the incidence. Okay, how can non-steroid anti-inflammatory drugs causes? They said that they inhibit cyclooxygenase 1 and 2 and eventually reduce prostaglandin. Prostaglandin play an important role in the healing of the epithelium of the bowel and repairing the epithelium of the bowel. Here is it. It have a crucial role in the epithelial maintaining mucosal defense and immunomodulation of the colon. So high dose of non-steroidal anti-inflammatory drugs play a role. The diet. And regarding the diet, some studies found that the use of meat and animal products are found to be a contributor or a risk factor for developing inflammatory bowel disease, and in contrast the use of fruit and vegetables are found to be protective or have a lower incidence of inflammatory bowel disease. Is this a direct cause, or it's just this diet will change the intestinal microbiome and the intestinal microbiome will affect the immunity in the intestinal lumen? We do not know. Okay, we reviewed the etiology. We say that it's not easy, it's not fully understood, it's multifactorial, and now we move to the diagnosis and evaluation. And here it's interesting to say that inflammatory bowel disease was first described in 1793 as a chronic idiopathic condition with genetic predilection and environmental trigger. Nice one. Okay, an interesting information that they said that even among immigrants who travel from areas with low prevalence of inflammatory bowel disease to high prevalence to area with high prevalence, such as those who travel from India to Europe, they found in these patients the incidence of inflammatory bowel disease will increase in them and their children. So this also highlight the environmental cause. About the clinical presentation, we know that the inflammation is the distribution of inflammation is wide, so that there will be a wide spectrum of symptoms, and these including, for example, change in bowel frequency, either constipation or diarrhea. It's correct to say either diarrhea or constipation. Crampy abdominal pains, we will know why crampy later. Actually, this is associated with obstruction, whatever, partial, total, fistula, stricturing, and also diarrhea. We say the blood in the stool, or with or without the blood, tenesmus, urgency, incontinence, food intolerance, anorexia, and weight loss. Okay, the patient can present with subtle or mild symptom, or can present with fulminant colitis. The patient can present with a chronically abdominal pain or acute severe pain. And acute severe colitis as a first manifestation. The patient can present firstly with the extraintestinal manifestation. So this highlights on the a full examination and full history taking. It's important in the history to evaluate the chronicity of the symptom, family history, we said, genetic predisposition, other risk factors such as infectious colitis or enteritis, risk for infectious colitis, and travel history. Also, recent antibiotic usage, recent non-steroidal. These should be taken with the history. Non-steroidal anti-inflammatory drugs, exposure to radiation, immunosuppressant, and of course the extraintestinal manifestation. All this will help us taking a proper history and exam and symptoms analysis, a chief complaint analysis. All these will help us in narrowing the differential diagnosis, but will not lead us to final diagnosis. About the inflammatory bowel disease phenotypes, and phenotypes means how it does ultimately finally appear on this patient. And we know that we have two phenotypes of inflammatory. I am trying to make the phenotype words more, make you more familiar with those phenotypes. Phenotypes mean either Crohn or ulcerative colitis, and we will see other subtypes and how they appear histologically, endoscopically, clinically, intraoperatively. We have to keep in mind in the next slides, in the next few minutes, that there are no one single test that will help us to say that this is ulcerative, or this is Crohn, or this is inflammatory bowel disease. It's a matter of collecting all the informations regarding the distribution of the inflammation, the microscopic and macroscopic appearance, the histological finding will help us to say that this is ulcerative colitis or this is and or this is Crohn's disease. Okay, regarding the Crohn's disease. And Crohn's disease was first described in 1932. We said before that in the 17th, so 200 years before, was described, but not in. They just describe, they just mentioned that there is inflammation in the bowel 200 years ago, but clearly described in 1932. They describe it as a chronic inflammatory condition of the terminal ileum leading to the development of structure and fistula. Okay, the terminal ileum is the most common site to be involved. We will see later. And actually, regarding the phenotype of Crohn's disease, it so the inflammation could be from the mouth to the anus, any part from the GI tract, with a skipped, we call it interspered with spared area or skipped lesion. Also, we have to know that all layers of the bowel wall are possible to be infected, and this may lead to the progression of fistula, structure formation, and even perforation, which is more common in Crohn's disease due to the transmural. All the layer of the bowel are affected. Okay. Also, unique for the Crohn's disease is the creeping fat. Creeping fat and mesenteric adipose tissue. You can see here that the mesenteric adipose tissue is invading the intestine itself. So this is adipose extending beyond the mesenteric border. Okay. Some theories said that the mesentery itself, the inflamed mesentery or the hypoactive mesentery, is an active mediator of local inflammation in patients with Crohn's disease. Hypothesis that the mesentery is an active mediator of local inflammation. Okay, here you can see the creeping fat in Crohn's disease, ulcerative colitis. Okay. In contrast to Crohn's disease, ulcerative colitis is a mucosal inflammation. Mucosal inflammation that involves the distal rectum. This is the mostly, we said there, the ileum, here the distal rectum, and they extend proximally in a continuous manner that involve the colon, which spare the small intestine and upper GI, and also the anus is not affected in ulcerative colitis. Okay, sometimes the terminal ileum is affected in ulcerative colitis. We will see later in the term backwash ileitis. Okay, here are some table. I know that we love as a general surgeons these tables that can differentiate between ulcerative colitis and Crohn's disease, but as an advanced understanding for this disease, we should know that this will help us. This will not give us the final diagnosis. We will see later. Okay. And these are the under the term phenotypes. Here we can see, for example, in this table, distribution regarding the distribution of the inflammation, ileal involvement and perianal disease. In Crohn's disease, any part of the GI system are affected, and the perianal disease are common. In ulcerative colitis, the distal rectum, and it extends in a retrograde fashion to involve the whole colon. Sometime we found backwash ileitis. The perianal disease is rare in ulcerative colitis. Bowel wall involvement, it's a full thickness in Crohn's disease. It's a mucosal inflammation in ulcerative colitis, and we will see in ulcerative colitis sometime perforation and a full thickness can be happened, especially in fulminant toxic colitis, which is more an ulcerative colitis. Skip lesion, yes, we have skip lesion in Crohn's disease. No, we have no skip lesion except if we are treating the patient, especially with enemas and suppositories. We can find some skip lesions. Creeping fat, we saw that it present in Crohn's disease. No creeping fat. Fistula, as we said, it's a full thickness in Crohn's disease, so fistula is possible and rare in ulcerative colitis. Okay, fissures and ulcers are common in Crohn's disease. Strictures are common in Crohn's disease if we compare to ulcerative. Another table, and I just added many tables because I know that we as a general surgeon love these table. You can take a screenshot. We will not go through every single one in a detail, but distribution, for example, here they mentioned the skip area. Here they said it's a continuous. About the location, they said here in Crohn's disease it is the terminal ileum. Here they said commonly the rectum. The extent, they mean the thickness, entire thickness. Here it's superficial, first Crohn, and here I mean ulcerative colitis, superficial in ulcerative colitis. Ulcers, serpingeous ulcer in Crohn and superficial mucosal ulcer in ulcerative colitis. Pseudopolyp are more common in ulcerative colitis. Fibrosis is more common in Crohn's disease. Shortening are more common in Crohn's disease due to fibrosis. We said transmural and mucosal and submucosal in ulcerative colitis. This is regarding the inflammation. Types of inflammation, it's non-caseating granuloma. Types of inflammation in ulcerative colitis is crypt abscess. Okay. The mucosa patchy ulceration in Crohn's disease, and hemorrhagic mucosa in ulcerative colitis. Okay. The megacolon is more likely to happen in ulcerative colitis. We said that fistula are more common. What's else? We here see some terms, for example, let me make a zoom in more. Here are the hose pipe appearance. These are with Crohn's disease. The hose pipe appearance, the couplestone appearance, the halo sign on CT, string sign of contour, and raspberry appearance. These are patterns found in the radiological study that can be found in Crohn's disease more, whereas pseudopolyps and garden hose appearance are found in ulcerative colitis. Here an interesting information. They say that the earliest change in Crohn's disease is an aphthoid ulcer, and the earliest change in ulcerative colitis is blurring of mucosal strip and granular appearance. Surgery is not a treatment for Crohn's disease, we will see later, or palliative for Crohn's disease and curative for ulcerative colitis. Another table, you can see they compare the Crohn with ulcerative. What can this table add to us? For example, here in Crohn's disease, the terminal ileum is commonly involved, but in ulcerative colitis, it's seldom involved. The colon is usually involved, but always involved in ulcerative colitis. The rectum is seldom involved in Crohn's disease, while it's usually involved in ulcerative colitis. Anus is commonly involved in Crohn's disease, while it's seldom involved in ulcerative colitis. The bile duct involvement, we will see later, it is higher in ulcerative colitis. Okay, here another, they also added an endoscopy that serpingians or snake-like ulcer is more common in Crohn disease. Another one is regarding the cytokine. They said that the cytokine T helper 17 are associated with Crohn disease, while T helper 2 are associated with ulcerative colitis. Regarding the granuloma on biopsy, they said that it is granulomas actually in Crohn's disease, non-caseating granuloma, while it is crypt granuloma. This is not seen in the granuloma is not seen in ulcerative colitis. We said smoking is a risk for Crohn and protective sometime for ulcerative colitis. Here are the term copplestone, which is found in Crohn's disease. It's sometimes called the Roman roots or copplestone appearance. Okay, another table. We try to find what we didn't say. Okay, we mostly said most of the information here. Here they say that fever is common in Crohn disease, while it's uncommon in ulcerative colitis, and mass in the right iliac fossa and appendicitis, mimicking appendicitis in Crohn disease, is more common than in ulcerative colitis. Okay. Okay, what we want to add also here, just remember, in ulcerative colitis, sometimes the terminal ileum may be affected in the term of backwash ileitis, especially if the cecum is the affected, so some adjacent inflammation to the retrograde inflammation of the ileum may happen. And another one scenario, if the patient is on a treatment, especially with enemas and with suppositories, in ulcerative colitis, we can find that the rectum is healthy. So we have to be careful about the rectum sparing type of ulcerative colitis. The endoscopist can find that the rectum is healthy, so we have to remember that. Sometime there will be an isolated inflammation of the cecum in ulcerative colitis, and this is, they call it the cecal patch. We said the backwash ileitis. Okay. And here is an entity called the inflammatory bowel disease, unclassified and indeterminate. And as we said, inflammatory bowel disease can be classified to Crohn's, ulcerative. We're still talking about the diagnosis and evaluation. But we have to know that despite all the diagnostic modalities regarding its clinical, its histological, macroscopic or microscopic, it's endoscopic, it is radiological, we will see later, sometimes we reach a point that we cannot differentiate, is it ulcerative or Crohn's, and the term inflammatory bowel disease, unclassified or indeterminate, present in about 10% of adult and 30% of pediatric patient. And actually, knowing is it ulcerative or Crohn's disease is extremely important, as it's guided our treatment, how we can follow up the patient. But actually, it's the diagnosis is a matter of a multidisciplinary team, and in many cases, the histopathologist raise his hand up and he say, I cannot determine actually. Okay. What I want to say that these patients who are labeled under inflammatory bowel disease unclassified usually present as a milder symptom and better response to treatment. About two-thirds of the patient are after 10 years classified as reclassified as ulcerative colitis. So reevaluation and reclassification is needed. Okay, these are the most important information about inflammatory bowel disease. About unclassified. About primary sclerosing cholangitis, if we want to talk about it independently. Okay, primary sclerosing cholangitis slash inflammatory bowel disease. Actually, primary sclerosing cholangitis is chronic liver disease characterized by duct inflammation and often progression to structure formation and bile duct involvement. We are not going to talk about primary sclerosing cholangitis in this lecture, as it will be discussed in the hepatobiliary lecture, but we have to know that about 3 out of 4 patients of primary sclerosing cholangitis will have inflammatory bowel disease, but only 2 to 4% of inflammatory bowel disease will have or will develop primary sclerosing cholangitis. So the hepatobiliary surgeon should be careful of the diagnosis of primary sclerosing cholangitis and think directly about inflammatory bowel disease. While the colorectal surgeon, when he diagnoses inflammatory bowel disease, okay, the primary sclerosing cholangitis can be happen, but in 2 to 4 patient, for 2 to 4% of the patient. Okay. The mechanism or the cause of the association is not clear. Some genetic predisposition regarding the phenotype. How can is it? It's an entity. I mean, these patients have something unique in a form of that they have usually pancreatitis with rectal sparing. I forget to say that it's more common, of course, in ulcerative colitis than in Crohn's disease. It is characterized by pancreatitis, rectal sparing, right side are more common than left side, higher rate, right side, higher rate of backwash ileitis, milder symptom despite endoscopic activity, and higher medical treatment response. Okay, and they are the primary sclerosing cholangitis and colonic inflammatory bowel disease have increased risk of developing mucosal dysplasia and cancer. Okay, let's move now to the extraintestinal manifestation. I know we started the topics, diagnosis and evaluation, but we have to know what are other subtypes. We said Crohn, we said ulcerative, we talked briefly about the phenotypes, we talked about the unclassified form, we talked about primary sclerosing cholangitis slash inflammatory bowel disease. This will help us, will guide us regarding establishing the diagnosis. We are coming to the diagnosis and evaluation. Now we should talk about the extraintestinal manifestation. And regarding the extraintestinal manifestations, about half of patients of inflammatory bowel disease have extraintestinal manifestation. About 1 out of 4, quarter of the patient with extraintestinal manifestations, the extraintestinal manifestation will be the initial presentation. Okay. The association between the extraintestinal manifestation and inflammatory bowel disease is not well known, but it may be explained, some genetic explanation. Okay. They sometimes really explain it by the HALA subtype. The most common extraintestinal manifestation is the joint involvement in about 40% of the patient. And also there is cutaneous, biliary, primary sclerosing cholangitis, and ocular, the eye, are also common. Okay, here are table that shows us. It's interesting, intrinsically to know that some extraintestinal manifestations are correlated or associated with the inflammatory bowel disease activity. Some of them we don't know, and some of them have no relationship to the inflammatory bowel disease or the gut inflammation activity. For example, this is called the inflammatory burden. So, for example, the cutaneous manifestations are such as the musculocutaneous are associated with intestinal activity, such as the oral or aphthous ulcer, the erythema nodosum. These are associated with the intestinal activity. The ophthalmic, the eye symptoms, such as the episcleritis, are associated with the intestinal activity, while it's unclear if the primary sclerosing cholangitis is associated with the activity, while the we said about the eye, the episcleritis is associated with the intestinal activity, while the uveitis is not clear if it's associated. Peripheral arthropathy, not clear association. Pyoderma gangrenosum, not clear. So some cutaneous and some joint manifestations have clear, and some eye manifestations have clear association, while other manifestations have no clear association. Again, regarding the skin or musculocutaneous, aphthous ulcer erythema nodosum is associated, while pyoderma gangrenosum not clear. The eye, episcleritis, clear association. Uveitis, not clear. Primary sclerosing cholangitis, not clear. Which is not associated with inflammatory bowel disease is the ankylosing spondylitis. Okay, the extraintestinal manifestation, another table also showing how the extraintestinal manifestation can present. For example, the skin, erythema nodosum, pyoderma gangrenosum, eye, iritis, uveitis, episcleritis, joint arthritis, ankylosing spondylitis, sacroiliitis, sclerosing cholangitis, gallbladder stone, renal stone, pancreatitis, chronic active hepatitis, amyloidosis, aphthous ulcer, anemia, thrombocytosis, DVT, arterial thrombosis. Okay. Here they say that it's important to figure this out by history taking and to determine if there is extraintestinal manifestation, as sometimes they aid our treatment, our medical or surgical treatment. For example, patient with primary sclerosing cholangitis, this push us toward the surgery, as primary sclerosing cholangitis have a risk of malignancy, so this pushes us toward the surgery. Other presentations such as anemia, osteopenia, cholelithiasis, nephrolithiasis, nephritis, interstitial nephritis, and venous thromboembolism are associated with inflammatory bowel disease as extraintestinal manifestations. Okay, diagnostic evaluation of suspected inflammatory bowel disease. And here we go to the laboratory investigations and the stool test. When after we finish our history taking, our assessment of vital sign, our physical exam of the abdomen, examination of the skin, inspection of the orbits, and perineal examination, digital rectal exam. So we move to laboratory test, and of the routine testing to do complete blood count, electrolyte, creatinine, liver enzyme, bilirubin, and iron studies. Regarding specific laboratory testing that we should know, the CRP or C-reactive protein, there is a correlation with the severity, especially with the severity of the disease, especially in Crohn's disease, but it is not sensitive enough to rule out infectious causes or other causes. Erythrocyte sedimentation rate, okay, it tells us that there is inflammation, but it is of a limited clinical utility in ulcerative colitis. Okay, we should think if there is diarrhea, we should think of a stool culture, especially to look for ova, parasite, and Clostridium difficile taxon. If there is a recent hospitalization or antibiotic usage. These patients who have receptive intercourse, we should consider swab for sexually transmitted disease. I know what you want to hear, the Bianca and Aska. Actually, they are not enough sensitive and specific, but the combination of both can help us. The specificity and sensitivity is high when they are combined together, but doesn't reach even 19. It's wisdom to remember that positive P anchor, negative A, ASCA negative, P anchor positive, this support ulcerative colitis. And in contrast, negative P anchor, positive ASCA support Crohn's disease. We said high sensitivity, high specificity, sensitivity to detect the disease, specificity to rule out the disease, high but doesn't reach the. Okay. One important test also is the fecal calprotectin. It's actually evaluate the burden or the degree of the inflammation in inflammatory bowel disease. It's not specific nor sensitive, but how it can help us. It can be, this just give us a reflection of the inflammation of the bowel. It can be inflamed in colitis, in cancer. It can be raised in colitis, cancer, diverticulitis, in patients who are in non-steroid anti-inflammatory drugs. But it helps us that there is a cutoff. If it's lower than this number, so we do not need an invasive procedure, and they say less than 50 microgram per gram. Here is at less than 50, so we do not need an invasive procedure. Why? It have a high negative predictive value. So this is the rule of fecal calciprotein. Regarding, here we finished the laboratory, we move to the diagnostic imaging. Regarding the diagnostic imaging, we have the X-ray, we have the CT scan, the ultrasound, and the MRI. Regarding the X-ray, it's of little or limited use except in cases of ulcerative colitis when it presents as a toxic megacolon and there is a dilatation of the transverse colon more than 6 centimeter. For example, you can see here how the colon is dilated more than 6 centimeter. This is the unique specific usage of the X-ray. Otherwise, it's not that helpful. Okay. Regarding the CT scan, actually, when we investigate for inflammatory bowel disease, it helps, the CT scan helps us in Crohn's disease more than in ulcerative colitis. We can study the small bowel, or what we call it the hard to reach on endoscopy area, hard to reach, such as the small bowel. So we can, it's better for Crohn's disease more than ulcerative colitis. Okay, we usually use in the acute setting the CT with intravenous and oral contrast. It can detect moderate and severe small bowel disease, as we said. It can figure out the intra-abdominal and perianal abscesses, the degree of bowel obstruction, what we are looking in CT. And also, there are some modalities of the CT with administration of the new contrasts such as low density or natural contrast, which is called the CT enterography. Actually, the CT enterography allow us to know the detection of the mucosal inflammation and the degree of thickness of the bowel. It's better characterized by CT enterography, and the structures, visualization of the extraintestinal findings such as abscesses and Here you can see on CT enterography how is the terminal ileum is narrowed. Then there is a leakage of content and the formation of abscess in the right iliac fossa in a patient with Crohn's disease. Again, what we can find on CT: luminal stenosis in case of structuring, increased wall thickness, pre-stenotic dilatation. Okay. We said that the problem with CT is the radiation, and there is the CTE or CT enterography, which try to make the radiation and its protocol lesser than that. Here you can see how is the ileum is constricted and there is pre-ileal or pre-stenotic dilatation in patient with the Crohn's disease. So the CT scan is a method for Crohn's disease more than ulcerative colitis. Ultrasound, yes. Also, ultrasound is what advantage can we take from ultrasound? That it's at the lower cost, radiation free. Also, in assessing the small bowel in a trained radiologist, the sensitivity reached up to 70%. It can detect the extent and degree of the inflammation, but this depends on the center and the availability of the ability of the radiologist, trained radiologist. Okay. Some newer technique in ultrasound, they use intravenous contrast enhanced ultrasound and ultrasound elastography, which give us an accuracy in a small series, but we need more studies. Of course, the ultrasound have an important role in that. Transperineal and transanal ultrasound is important in perianal fistula and abscesses. MRI also, it's better than ultrasound a little bit, but if we want to arrange them, the best is CT, then MRI, lastly the ultrasound, the MRI and CT, MRI, ultrasound, MRI. Also, this depends on the availability of this modality. It's higher cost, dose, radiation free. Of course, we have magnetic resistant enterography, MRE. Again, it depends on the center, and we can add, it is good to detect the colonic disease, the extent of the disease. We said, okay, they are talking about that there are new techniques. It's important to know that the MRI is the gold standard for patients with Crohn's disease and anal and perianal conditions such as fistula and abscesses. Here you can see how the wall is enhanced in patient with Crohn's disease and delayed enhancement and stenosis in patient with Crohn's disease on MRI. Here you can see how is fistula, transsphincteric fistula present in patient with Crohn's disease. So it's standard for patient with Crohn's disease and with Crohn's disease with perianal Crohn's disease. Okay, endoscopy. Okay, and here when we are talking about endoscopy, we should consider also the terminal ileal intubation. We should reach the terminal ileum. It's the gold standard diagnostic test for patient with symptoms suggesting inflammatory bowel disease. Two biopsies should be taken from the terminal ileum, from the ascending, transverse, descending, and sigmoid, and rectum, and reviewed by the GI pathologist if available. Of course, there are many scores for endoscopic severity, and they always advise the locally accepted score. And here a table, they just identify the terminology that the endoscopist can use. What does mean granularity? What does erythema mean? What does loss of vascular pattern? The surgeon should be oriented in this because the patient will return back from the endoscopist with these reports, and he should know what does this mean. Here you can see, for example, I will not go for every single one as details, but for example, erosion means a definitive discontinuation of mucosa that is less than 3 millimeters. What does ulcer mean? What does stenosis mean? So they do not give you time for your imagination. They define every single point. Actually, I don't think that we have to go every single one. You should just be oriented of these. In cases of severe acute colitis, it's enough to go just for flexible sigmoidoscopy with biopsy. Actually, this will help us at least to rule out infectious causes. And it will help us. Sometime, actually, upper endoscopy is not required in cases of inflammatory bowel disease unless it's Crohn with upper GI involvement. Of course, endoscopy, and we have to reach the whole bowel. It's not an easy mission for the endoscopist. Sometimes they use the push technique or double balloon technique to reach the small bowel. Sometimes they use the capsule to study the bowel. With regarding the histology, actually after colonoscopy we take the histology, we take the biopsy. What I want to say, even the histopathologist frequently can not determine is it ulcerative or Crohn's disease. You can here see the percentage, and about the diagnosis is usually in 70%, but 30%, as I said, the pathologist can not determine and raise his hand up. Okay, how is the microscopic manifestations of ulcerative colitis? For example, on ulcerative colitis, the problem is in the crypt. In histology, the crypt abscesses and cryptitis is seen in the histology. Here you can see the neutrophils, while in while in Crohn's disease, it's most likely to be granuloma formation. Here you can see the granuloma, and here you can see the crypt, abscesses, and ulcerative colitis. And here are summary of the histological finding on ulcerative and Crohn, I want to pay attention that this is ulcerative colitis and this is Crohn disease. Okay, for example, if we, for example, in ulcerative colitis, the acute inflammation is usually diffuse. Here we are talking about the histological manifestation. The crypt abscesses is common, mucin depletion is present, neural hyperplasia rare, muscular hypertrophy absent, Paneth cell metaplasia present, and pyloric gland metaplasia rare. It's actually it's better to read them to compare the ulcerative and Crohn's. For example, acute inflammation is diffuse and focal in Crohn disease. Crypt abscesses is common in ulcerative, it's uncommon in Crohn disease. Mucin depletion is common in ulcerative, uncommon in Crohn disease. Neuronal hyperplasia, common in Crohn disease. Muscular hypertrophy, present in Crohn disease, not present in ulcerative colitis. Paneth cell, present in ulcerative, not present. Paneth cell metaplasia, not present in Crohn disease. And pyloric gland metaplasia is present in Crohn disease, not present in ulcerative colitis. Okay. We said that the pathologist cannot be able to accurately determine. Okay. About the genetic study, do we do routine genetic study? No, there are certain indication. There are the genetic study is not an easy. There are more than 240 loci found in the gene that may be associated with inflammatory bowel disease. So our guideline when to do our indication when to do a genetic study, for example, here they summarize it. First of all, in patient with suspected monogenic disease, we said it's usually the Crohn disease, the inflammatory bowel disease is polygenic. But if it is suspected monogenic disease, when we will explain, such as patient with interleukin 10 receptor mutation, those with early onset of the disease, less than 5-year-old, we have to do genetic testing. These with young patient with aggressive or refractory inflammatory bowel disease, we should do genetic testing. And we will see later those who we want to start them with thiopurine medication. Some patients have thiopurine deficiency, and we have to do genetic testing before that, before we give the treatment. So this the indication: suspected monogenetic disorder, interleukin 10 receptor mutation, early onset, young patient with aggressive or refractory inflammatory bowel disease, and patient who are with suspected thiopurine mutation of thiopurine metabolism and are going to take thiopurine medication. Okay, regarding the classification and grading. Okay, I don't want you to get confused because it's a little bit complex, but classification is extremely important regarding the treatment, regarding how the multidisciplinary team, the surgeon, gastroenterologist, histopathologist will communicate with each other. There are many scores according to the clinical severity, according to the endoscopic severity, the activity of the disease of them. And we have to remember that the nature of the disease is chronic, so reclassification is frequent. One can move from one class to another. Okay, regarding the classification of the clinical classification of Crohn's disease, we have the Montreal and Paris classification, and these have certain parameters, including the age of diagnosis, less than 17, between 17 and 40, more than 40, and the location, is it in the terminal ileum, in the colon, ileocolon, or L for upper GI. Behavior, is it non-structuring, non-perforating, structuring? You can just A1, A2, this is the age. L, this is the location. P, this is the behavior. P3, for example, penetrating, perianal disease modifier, and growth delay G1 and G0, no growth delay G1 with growth delay. These are Montreal and Paris classification for Crohn's disease. For ulcerative colitis, we have Montreal and Paris classification, but with different parameter. For example, here we have the extent of the inflammation. For example, is it proctitis, the rectum only, left side, or extensive ulcerative colitis? And plus we have the other parameter, the severity. So what play a role in the classifications of ulcerative colitis? The extent and the severity. Severity, the letter S, S0, clinical remission, mild symptom, moderate symptom, severe symptom. These are mild, moderate, and severe is another classification. We will see it later. But don't worry, we said that there are the clinical classifications according to Montreal and Paris for Crohn and ulcerative, but the parameter is different in each classification. The endoscopic score also, I don't want you to be confused, but regarding the ulcerative colitis, it is the endoscopic subscore of Mayo. It's how the endoscopist will tell us the score, and you can see here when the endoscopist take the specimen, it's about 1 to, here is the segment is the rectum. He take biopsy from the rectum, the sigmoid, the descending, the transverse, and ascending. They should be five specimen, and each specimen are examined by the histopathologist and take a number from 0 to 3. Okay, so the maximum is 5 multiplied by 3. Okay, this will be 15 multiplied by the length of the segment involved divided by how many segments are involved. Is it 1 to 5? From 1 to 5. This gives us the, what we call it, the endoscopic score for ulcerative colitis, MMES, or subscore of Mayo. The endoscopic Mayo score, the endoscopic subscore of the Mayo score, and the modified Mayo endoscopic score, modified Mayo endoscopic score. So this is how the endoscopic score for ulcerative colitis. For here you can see how is Mayo, I think one, how is different Mayo present. These are endoscopic score till the last one. Okay, Mayo 2, Mayo 3 colitis. Oh, just we have to be oriented in that. Regarding the endoscopic evaluation of Crohn's disease, it is what we call it the simplified endoscopic activity score for Crohn's disease. CIS Crohn's disease. We are talking about the endoscopic classification of Crohn's disease, and the parameter are size of the ulcer, ulcerated surface, affected surface, presence of narrowing. We take how many specimen from the terminal ileum, from the right colon, from the transverse colon, right colon, transverse colon, from the left colon, and the rectum. And every specimen will take a number from 0 to 3. And we will have the score. Okay, this is again the endoscopic score for Crohn's disease. We call it again the simplified endoscopic activity score for Crohn's disease. These are the parameter. Okay. Again, what's this? This is how Crohn's disease looks like according to the endoscopic finding. Activity score. Okay. Regarding the activity score, as we said in ulcerative colitis, you can see here, this is a entity called the severity, called the pediatric ulcerative colitis activity index according to mild, moderate, severe. We will see it later. It's called true love, something like that. We will see it in the next few minutes. This is how ulcerative colitis is classified according to the activity. And regarding Crohn's disease, we have the Harvey-Bardshaw index for Crohn's disease. And what is interesting for us is to know the parameter of each score. For example, here in Crohn's disease, the general well-being, the presence of abdominal pain, number of liquid stool per day, abdominal presence of abdominal mass, and the complication. These are the Harvey-Bradshaw index for Crohn's disease. Okay, I know it's a little bit, but again, to review, there is clinical classification for Crohn and ulcerative. These are Montreal and Paris, but with different parameter for each, for Crohn and ulcerative. There is endoscopic score. This is the MES for ulcerative and CIS for Crohn's disease. What I mean by MES, here is MES. We said modified. It is the modified Mayo endoscopic score for ulcerative and the simplified endoscopic activity score for Crohn's disease. And regarding the activity score, we said that these are mild, moderate to severe. We will mention it later. It's called, I think, true love, something like that. The severity of the ulcerative colitis. And regarding the Crohn's disease, Harvey-Bradshaw. Of course, there are many classifications of them. For example, here the Crohn disease activity index, but we just reviewing that. And the parameter are the general well-being, abdominal pain, number of liquid stool, masses, and complication. We move to the surveillance on endoscopy. Surveillance endoscopy for inflammatory bowel disease. And if you are talking about surveillance, so we fear of colorectal cancer. Okay, about colorectal cancer, and there is a category that is on high risk, so we have to follow them. Of these patients are those who are with early onset of the disease, with long duration of the disease with active disease, with structuring, with primary sclerosing cholangitis, with family history of colorectal disease are at high risk. When to start the surveillance? Actually, the data is of low support, but till now we can say that after 8 years, where is it written? After 8 years from the onset of the symptoms, or when we diagnose the patient with a primary sclerosing cholangitis, inflammatory bowel disease. When primary sclerosing cholangitis, inflammatory bowel disease, directly go for colonoscopy, or after 8 years from the onset of the symptoms. Of course, here we are talking about patients who present with inflammatory bowel disease, except in these patients who present with only proctitis. Proctitis doesn't need to be followed with colonoscopy. Okay, here is it. Here is the information. For all patients with ulcerative colitis and Crohn's disease involvement, but excluding patients with history of proctitis alone, we said 8 years after the. Okay, they also talk about the modality of colonoscopy. There is what we call it the chemo endoscopy. They use certain stain to detect the lesion or dysplasia. The study still about this entirety, but there is what they call it the high definition, not only the chemo, but the high definition colonoscopy. They recommend, if available, high definition. Here is it. Sorry, high definition colonoscopy. They recommend high definition colonoscopy with chemoendoscopy if available, as it can detect the dysplasia early. Okay, we said, also, how many biopsy we should take. Actually, the number is huge. 4 random biopsy should be taken every 10 centimeter and then should be reviewed by the GI pathologist. Again, the patient with a high risk, such as primary sclerosing cholangitis, family history, dysplasia, should undergo, the interval should undergo annual surveillance colonoscopy, while those with moderate or intermediate risk, those, for example, those with active mucosal inflammation, should undergo surveillance every 1 to 3 years, and these with low risk should undergo surveillance between 3 to 5 years. Again, after 8 years from the diagnosis, or when primary sclerosing cholangitis present, and the interval according to the risk. If high risk, we go annually. If moderate or intermediate risk, we go every 1 to 3 years. Or if low risk, we go every 3 to 5 years. Actually, we send these to pathologists, and the old term, which was dysplasia associated lesion or mass, I don't know if some of you read such as DALM or dysplasia associated lesion or mass. It is an old fashioned, not used recently. Now, the description of the dysplasia, the description of the tumor, or description of the pre-malignant condition should be precised by the by the histopathologist. And here they give you the guideline of the lesion that we can find while in our surveillance. For example, if there is visible or invisible dysplasia. Visible dysplasia means the colonoscopist saw a lesion and the histopathologist confirmed it. Invisible dysplasia, the colonoscopist didn't see the lesion, but a random biopsy taken, but the gastroenterologist, the pathologist identified the lesion. Also, polypoid lesion, pedunculated or sessile, pedunculated, the protrusion is more than 2.5 millimeter, with stalk present, sessile, no stalk at the mucosal level, non-polypoid, superficial, elevated, flat, breast, ulcerated, distinct border, indistinct border. So the word, the old term, dysplasia associated lesion or mass is out of service. Now we have precise description for every lesion on surveillance colonoscopy. Okay, now let's reorient ourselves. We talk about the diagnostic modality. We saw how is the history is important. We talk about the examination, how to review the extraintestinal manifestations is important. We also talked about the how the laboratory testing is important. We review what are the laboratory testing, the histopathological finding, the colonoscopy and endoscopy. We saw the imaging modality and the CT scan, the MRI, the ultrasound, and the limited significance of X-ray. We talked about the surveillance. I'm trying to just take a rest and reorient ourselves. Actually, a question appear here. Is it mandatory to know all that? And especially we are going in the next few minutes to talk about the medical treatment. And the answer is yes, at least to be oriented, at least to know what they are talking about. Because even as a surgeon, you are one or a member of the multidisciplinary team regarding the inflammatory bowel patient. You have to participate in the decision. The gastroenterologist, the histopathologist, the surgeon, the radiologist, all will communicate even at the level of the diagnosis, not only at the level of the surgical treatment. So we have to be oriented. Okay, now we move to the